So we'll see what's good today. So how's your weekend? Need another one? Well, we're going to get one. The one coming up is a 4-day for me because I'm going to take off Friday, and there's no class Monday because that's Labor Day, right? Make sure I'm correct on that and not misleading you. Yes, it's Labor Day. And so Tuesday when we come back following Labor Day, I think that's a great opportunity to test your knowledge. I call them picnics. We'll have a picnic on Tuesday. And I'll send out an ingredient list this week sometime in Canvas of what I would expect you to bring to the picnic. Make sense? And we'll take our exam, and that's all we'll do that day. You'll take it on the iPad, you will get up and leave, and then that's it. Yes, Derek?
Is that the airway?
Yes. So it kind of gives us an idea of what we're going to be doing for that. We need to finish up our physiology lecture, and we ended with cardiovascular system. We talked about the airway system. We talked about the Fick principle. We talked about blood and its components, the exchange of gases through diffusion. So we kind of know how the railroad track works, if everything's working correctly, but now we're going to mess it up and talk about shock. So as I go through the PowerPoint, this is chapter 13 in your textbook, and at the end of chapter 6 in your textbook, there's about 2 pages dedicated to shock. Well, efficiency, lack of trying to repeat myself, I'm just going to start here and run through the first little bit of this chapter. We will not finish chapter 13. We'll refer back to it when we get into treatment. If you're following along in the textbook, you may see a patient assessment chapter coming up and wonder why I'm skipping over that patient assessment. So I have a theory, and I think it's correct. Why assess something when you don't know what you're looking for? Does that make sense? So I'm going to assess someone who's either sick and or injured. That's called the patient. And I'm going to do a head-to-toe assessment. I'm going to do a primary assessment, a secondary assessment, all these assessments. And if I don't know what I'm looking for abnormally, then I really don't know what I'm doing. So I'm going to hold the assessment chapter off till about week 7. At least you'll have done medical. And then I'll repeat the assessment chapter when we do trauma, as that applies to trauma. Does that make sense? I don't know why authors put it so early in the book, other than the fact that it's just listed that way in the DOT curriculum. But if I was to write the textbook, the assessment chapter would be the last one you would look at. So don't be alarmed and think I'm skipping over that, because I'm not. You just need to know the disease processes in order to do that. You'll also notice, and I need to make mention of this, at the beginning of each one of your chapters is the National EMS Education Standards. And we look at those, then we write the chapter. We look at those and then we write the chapter, or they write the chapter. So when you say, what's the National Registry test look like? What do I study for? How do I prepare for it? This is a good place to start. So at the end of this course, you should be able to look back at this and say, can Riley apply fundamental knowledge, cause patho management of shock, respiratory failure, cardiac failure, and post-resuscitation management? At this point, I don't hold her to that standard yet, but at the end of the course, I will. Hell, at the end of the day, I will. That make sense to you? So we always post these at the beginning, or they do, just to tell you where the chapter comes from. So these are the standards you are judged against. And if I may, since we're talking about a test within a week, a little over a week from now, may I try my darndest to tell you you're not being judged against each other when you get your test score. So if you made a 72 and you made a 82 and the cut score was 70, both of you met the standard. Okay? So the test is really a pass-fail. Don't get hung up on he's always scoring 5 points more than me. It doesn't matter to me. What matters to me is you make the cut score. Those are called competency-based exams, judged against a standard, not each other. Now, if you take an ACT test or a fire department entrance exam written test, and they want to rank you from the top to the bottom, they want to take the top 10%, that's called a norm-based exam. That's the one you took in high school where you fit the curve, and the C people were at the peak of the curve, and you had the B's and the A's and the D's and the F's. That makes sense? These tests aren't graded that way. They're graded against the standard. So that's really hard for people coming out of high school recently to understand. It's even hard for some college students in other courses. You have to meet the standard. It's basically a pass-fail. All right. So the second one is the patho. Who can tell me what the word patho means, or the prefix patho? Disease. And physiology is what? More specific. How it works. Yeah. Study of the human body. In other words, how does it work? So you put the two words together, what are you saying? Huh? That's called pathology.
And how they work against the human body.
How the disease affects the physiology of the human body. Yes. So pathophysiology. Up until this point, we've been talking pretty normal, haven't we? The normal anatomical position, how the heart works, how the blood works, blah, blah, blah. And now we're about to insult the body. And that's why you're here. That's why you're here. We're about to insult the body. So let's get going. I need a definition of shock. There's one on the board or the screen. Inadequate cellular perfusion. So we need to break that apart. There's a lot going on there. Inadequate means, Amber? Inadequate means?
Not to satisfactory.
Not enough. Yeah, not enough. Cellular, the cells of the body, and then take the last word, Gus, perfusion. See if you can define perfusion.
The amount of blood that goes to the cells.
Nope. I won't buy that. I won't buy that. You're getting closer, but you're not complete. Okay, so gases exchanging what? We had a word for that. When gases exchange, it's called?
Respiration.
Yes, respiration. So you telling me we must have respiration in order to have perfusion?
Yes.
Okay. Is that it? I don't think so, or they'd put the word respiration up there. But it is one part of perfusion, isn't it? And I got to get it there, and that's what Gus is saying. I've got to get the red blood cells there, right? Would you be okay saying that perfusion was the Fick principle? The trains, the boxcars, the railroad tracks, unloading and offloading. Could you say shock, by definition, is failure of the Fick principle? Would that work? Luke, will perfusion work without the Fick principle? No. No. So Gus says I got to get it there. Billy says I got to unload and offload the gases. What else does it take? Okay. Got to have cardiac output. And one more thing. A network of vessels to get it there and back. A network of vessels to get it there and back. Not only a network of vessels to get it there and back, but that network of vessels must stay intact. It must stay intact. You can't have a bridge, a railroad bridge or a trestle blown up. The Fick principle fails. Can't have a hole. Can't have a derailment. It's all got to be intact. Inadequate cellular perfusion, you could say inadequate tissue perfusion. Let's go through this hierarchy of why you're human. So what's the basic building block of a human? A cell. And a group of cells coming together to form a common function, form tissue. And a group of tissues coming together to form a common function, form an organ. And a group of organs coming together form an organ system. And an organ system coming together, organ systems coming together to work as a whole causes a organism. And that's what you are. You with me on that? So if the cell's not being perfused, what's happened to the organ or in the tissue? And the human as a whole? Starting to die, isn't it? Starting to become, what was that big word again that started with an IS? Ischemic. Boy, some of these markers need a ischemic, meaning the perfusion's leaving. So shock could be ischemia, couldn't it? You're going to find a lot of definitions for shock. I think that first line up there says lack of perfusion to the cells leading to ischemia. Now, some tissues in the body are more sensitive to ischemia than others. So we call those ischemic sensitive tissues. Ischemic sensitive tissues. Can somebody give me one? What tissue in the body you think is very sensitive to ischemia? Heart? Okay, sure. Sure. Heart? Brain? No, and I'll tell you why here in a minute. Not any organ. At some point they all are sensitive to it, but as we talk about shock, we talk about protecting our ischemic sensitive tissues. And so does your body. Your body hierarchies, if you will, the tissues are going to get blood and not going to get blood. In order to feed the brain, I have to take the blood away from something else. One of the things it takes it away from is the skin. Remember we talked about alpha 1 pulling blood toward the periphery or from the periphery to the core. And the reason alpha 1 works is this. Give me some more. Heart, brain, liver's out there. That's a lymph node. Lungs. I'd add one more to the list. Yes, kidney. I simply say heart, lung, brain, kidney. Liver's out there too. But the liver is so rich in blood anyway that it's kind of hard for it not to get blood flow, because as the descending aorta comes out of the heart, out of that left atrium, one of the big arteries is the hepatic artery. So the word hepatic means liver. It's your word of the day. Hepatic, H-E-P-A-T-I-C. Hepatic means liver. You'll see that word a lot, so I'd make sure I knew that. These are ischemic sensitive tissues. The body will protect those. And even those have a little bit of hierarchy. Which one of those do you think the body will get rid of first if it has to get rid of one of these? Kidneys. What organ will it protect at all cost?
The brain.
The brain. It's going to come back to play here in a little bit, okay? All right, back to the definition. Does anyone have another definition of shock? Even if it is less than textbook. Sepsis, that's a form of shock. And we'll talk about that one today. Here's one I don't want you to say. Low blood pressure. I don't want you to say that. Low blood pressure. In late stages of shock, the blood pressure will be low. I said late stages, so that means we got stages in front of that where the blood pressure doesn't change or may even go up. We'll get into that a little bit. I just do not want you to use the definition low blood pressure. That's where that comes into play. That's exactly where that comes into play. Inadequate cellular perfusion. Some people will use the term hypoperfusion. I'll buy that. I'll buy that. That's the same. That's saying the same thing. Hypo means low. So low perfusion, hypoperfusion. I think that says the same thing as inadequate. So here's the critical thinking question. Here's the non-trivia question. Christian, you want to tackle it? Here's the non-trivia question. How do I know if someone's in shock? You just did what I told you never to do. You just did it. I baited your ass. I threw the lure and you like, that's a nice worm. And you, it's just got a little hook in it. It's got a little sharp hook in it. Caught you.
I was going to say low blood pressure,
Okay.
altered mental status, fever.
None of those are inaccurate. None of those are inaccurate. But they're late. None of those are inaccurate, but they're late.
If they're pale.
That may be even a little later. You're backing up some, but
Modeling a little bit? It'd still be.
so you got all these signs and symptoms, and I think you proved it for me. And Christian, he was sitting there critically thinking, and he's like, "Man, I'm glad you took that off of me." He owes you one, doesn't he? There's no one thing. There's no one thing. Everything you mention, if I see that on the patient, oh yeah. Measurable. I can put numbers to it. But where am I at in the process of treating it if I wait to find something like you mentioned? I'm in the decompensated side of this, and we haven't gotten there yet, but
The real way is to test it.
we're late. We're late. Okay? The real way is to do some blood tests, gas analysis, lactic acid levels, blah, blah, blah. I don't have those. This is all I got. I got my senses. That's all I got. Yeah, it's a trick. It's kind of a trick.
So,
Go ahead. I'm sorry.
yes, question one more time before I think of what I'm about to say, because it just sounds stupid.
No, go ahead. Say it.
So would you almost be late to realizing it's shock because it can come in different forms and ways by the time you realize it?
The non-expert, somebody who is just learning the trivia and not the critical thinking, you're absolutely correct. You may be so blind, if I should say that you're like, oh, here it is, but it was there all along.
Yeah.
It's sneaky. Shock is sneaky. So Remember that Lord Kelvin guy? Oh, what?
You would do the palpating of the skin. Of the,
You could?
and that would, you didn't have
You could?
core perfusion, so you wouldn't have rebound.
Or you could just be cold. So, yeah, it's a trick, guys. Shock is sneaky. It's like a serpent. It crawls quietly, but when it strikes, it hits hard. So let me use an analogy if I can. If you're walking through the woods and it's swampy and there's a lot of litter on the ground and a lot of dead logs and stuff, do you not think to yourself, I better keep an eye out for snakes. This looks like snake territory. You may never see the snake, but why? What are you doing when you go through there? You're alert. Why? So you assessed the scene, didn't you? Your scene was, I'm in the deep woods with a lot of dead logs and litter on the ground. This looks snaky. May never see the snake. How does that apply to us on a scene? This scene looks like someone who could be in shock. I don't see shock as far as a number or a set of vital signs or some skin conditions and things like that, but it just looks what they probably should be in what? Shock. Okay, let's clean it up, make it easier. You slam into a bridge abutment at 70 miles an hour in your 1964 Cadillac that you're so proud of, and the brakes failed. And you're on scene now with that patient. This scene looks snaky. It looks like there's probably shock. Therefore, I'm going to wear tall boots and make noise and get my point. Therefore, when I get on scene with this patient, I'm going to treat them and act as if they are in shock, even though I don't see any outward symptoms yet. You following along? What happens, and this is back to that question, Billy, what happens if I wait till the snake has its fangs in me to act?
Too late.
It's too late, isn't it? So if I wait to see the low blood pressure, the altered mental status, all these things, that I'm behind. Now, I brought up Lord Kelvin for a reason, and he said, this is his definition of shock, and it's the best one I've ever heard. And you go back that far in time and get some of the best information. The rude unhinging of life. The rude unhinging of life. Those of you who came in early today, you heard Dean in here, and when he left, he said, oh, you're going to talk about shock? And I said, yeah. I said, everybody who dies goes through shock. Okay? Rude unhinging of life. When you die, you will have went through shock. Sometimes within seconds, sometimes over days, weeks, months, maybe even years. Because as that process starts and that unhinging is not corrected, now we're into these things. How well do you live without your kidneys? Can you live without them? Sure, there's dialysis, there's kidney transplants and stuff. How well do you live without your kidneys and your lungs? Oh hell, that's going to be hard. How well do you live without your kidneys and your lungs and your heart starting to become damaged? How well does the locomotive move the boxcars down the railroad track if all that's in play? It's not uncommon for an EMS person to treat someone on scene and do the very best they can and get them to the hospital, and the emergency room does the very best they can, and they're admitted to ICU, and they're in there for 2 or 3 days, and you're like, I feel good about what I did. And then on the 3rd, 4th day, they're being carried out in a funeral home gurney with a purple sheet pulled over them, purple blanket. You go, what happened to Johnny? I thought we put Johnny back together. I tied the tourniquet, the ER pumped him full of blood. Trauma surgeon opened up his chest and sealed off the leak. What happened to Johnny? Well, those ischemic sensitive tissues were getting damaged during all of that, and you just didn't see it yet. You just didn't see it yet. He was in what we call irreversible shock. So much tissue ischemia had occurred that no matter what we do, it can't recover. Now, we talked back in our health and well-being lecture about the more medicines you have on board, the weaker you are when you start out. If you've already got diseased lungs, if you've already got kidney problems due to diabetes, how compounded. Do you know what exponential growth is? I'm still waiting on it in my retirement fund, I promise you. Exponential growth is we start out here and then we just really start climbing. So this tissue ischemia is kind of like that. We can get by for a little while, but once it starts to climb, now comorbidity factors change the curve to start occurring earlier. Resilient, young, healthy, in shape, no medications, they run out here before they start climbing up the curve. And that's where you want to be in your life. One blood pressure medication changes the shape of that curve. One blood pressure medication plus diabetes changes the shape of the curve for the worse. Does that make sense to you? So do I have to consider those comorbidity factors when I'm looking at a patient who probably is in shock even though they're not showing it yet? What about my scenario I painted for you with the bridge abutment? Told you there might be shock involved. New term alert. That term is called mechanism of injury. And I'm going to abbreviate that, MOI, mechanism of injury. Little Johnny in the toddler pedal car who runs into the fireplace at home and doesn't even get knocked out of his little plastic car and kind of laughs at you when he does it, like, I crashed, Daddy. What's the mechanism of injury there? Probably not very significant, is it? There probably isn't even one. Unless you knocked Mom's vase over and broke it, then you're going to find a new injury, right? 60 miles an hour in an old car, and I use an old car for a reason because it has less safety standards. Slamming into a bridge abutment has a significant mechanism of injury, doesn't it? What we call high index of suspicion. Maybe that's how you define shock. I find a patient with a high index of suspicion. Works for me.
So say they're not in a car wreck or something along those lines.
Mm-hmm.
They're still in like septic shock.
Okay.
What would you use then?
So that's not an injury that causes that, is it? That's more of a medical cause. Then I'll give you your other word. You want your other word of the day? Nature of illness, NOI. So people get sick and injured in two ways. Either they have an injury through trauma, that's the mechanism of injury, or they have an illness, nature of illness. Are they both, whether it's the car accident or the septic shock you speak of, one trauma, one medical, are they both leading to inadequate tissue perfusion? Are they both leading to the root unhinging of life? Do they both have their own special way of being treated? So your chapter 6 in your book, if you've got this, fine. If not, you don't have to turn to it. But I'm going to go back to chapter 6. And it's toward the end of the chapter, page 238, 239. 238, 239 in your text. It has a table there, and it's got all the different types of shock. And we're going to go over those individually today. But they both lead to the definition on the screen. I say they all lead to the definition on the screen. Okay. So the patient has started to enter shock. Now the body has to do something about it. And do you realize that some of you right now, maybe even self included, is going through maybe a compensatory phase? Here's an example. You've been outside, you've been working, you've been mowing the lawn, it's 110 heat index. You're not drinking enough fluids, or maybe you're drinking fluids that aren't good for you necessarily and further dehydrate you. And you go to urinate and your urine is dark yellow. What's that an indicator of? Dark yellow urine. You're not hydrated enough. And your body is holding on to water because it needs to hold on to water, but it still needs to get rid of the waste, so it'll just concentrate the waste. Right? If you were well hydrated, you would urinate clear, even if you're sweating profusely, but you're still urinating clear. You didn't necessarily go into a form of shock that caused injury, but you were stressing the kidneys, weren't you? You were stressing the cells. They weren't homeostatic, but it was a very early, what we call compensatory mechanism to hold that fluid in the body because you were running low on it. Some of us may be in that position right now. Maybe the weekend was too fun, and your body tried to compensate by getting rid of the alcohol or something. Y'all want a new medical term? Abbreviation? ETOH stands for ethyl alcohol. That's the kind you drink to get drunk. Or maybe not get drunk, but maybe just whatever. For recreational consumption, let me put it that way. Ethyl alcohol. ETOH. So good place to throw down a new term, a new abbreviation for you. Okay. We've already done this one, so just as a recap, we perfuse to diffuse. We perfuse in order for Gus's diffusion to take place. So we had to perfuse all the cells with oxygen-rich and nutrient-rich blood, and we have to clean up the cells. We also have to act as their waste management and get that stuff thrown out of the body because that's not good for us anymore. So in order to have diffusion, we better have perfusion, both at the alveolar level and at the cellular level. So it's got to work both ways. It's got to work both ways. Throw a question at you and see what you do with it. Will hypoperfusion lead to hypoxia? Hypoxia? Could. At least at some tissue level, you may be hypoxic in the little toe, but not hypoxic here in the early stages of shock.
Is that what causes the alternate?
Mm-hmm.
That was some older people, and it's like 70s and above. That's why they have like some part of their skin like in blue sometimes.
Yeah, poor perfusion to that area. Can hypoperfusion lead to low O2, that's hypoxia, and high CO2? Certain areas of the body, depending on how severe the stages are, sure. So we know low O2 is hypoxia. Low O2 in the blood is hypoxemia, because emia means blood. Do I have a word, Jordan, for high CO2? You would be correct. Hyper, because hyper means a lot of, right? Capnia. hypercapnia. Does inadequate tissue perfusion potentially lead to hypoxemia or hypoxia? Yes. Does it potentially lead to hypercapnia? Yes. Because diffusion fails when perfusion fails. Perfusion, no, I don't even know what I said. Diffusion fails when perfusion fails. Thank you. Thank you. So if diffusion fails, we get hypoxic in certain tissues, and we become hypercapnic. Now, Jonah, I would say hypercapnia can cause just as much altered mental status as hypoxia. We're going to find out later this week that actually the stimulus to breathe isn't O2 levels, it's CO2 levels. And I've got a great example of how that works. Do you guys know what free divers are? They ride the sled on one breath of air as far down in the ocean as they can go until they give up and say, I got to get back to the surface because I need to breathe. Okay? And these people set records, you know, who's got the deepest dive riding a sled on one breath of air. What do they do before they submerge themselves? What do they do before they take the nod and go under?
Breathe.
How?
Breathe in. Take a breath.
How are they breathing?
Don't some of them just like breathe in and out and fast?
So they hyperventilate themselves.
Have too much oxygen, right?
They hyperventilate themselves. They're sitting there prepping. What are they doing? Physiologically speaking, what's happening?
Too much oxygen.
Nope. You cannot store oxygen in the blood. But what is the stimulus to breathe? CO2 levels. So when they're breathing fast like that, they're not storing oxygen. Remember that pulse oximeter thing we talked about? As long as it's better than 94%, we were good. Most people run around 97, 98. 97, 98. That's 97, 98% saturated. You don't have much more to store, do you? You're almost already fully saturated right now if you're healthy and normal. But the stimulus to breathe is CO2, so if I get all that away, if I blow off more than by the time I get to that stimulus line, you with me? When do you take out the trash? In your house, when do you take out the trash? Do you, or do you play the game like we play at our house called Stack the Trash? Let's see how high we can get it before it falls in the floor. Right? I mean, we got a trash can with a lid. It's full, but the lid will close. Then we just prop the lid up and pack some more on top of it. And then there comes some point the trash spills in the floor. And you're asking yourself, what's the point of you saying this, Brandon? Hey, if I went and got the trash can and emptied it when it only had that much in the bottom, I would have more days to build the trash up, wouldn't I? If I purposely get rid of all the CO2 in my blood, then I can build up a whole lot more before I ever come back to the line that says breathe. So that's what the free diver is doing. He's getting rid of that. How does that apply to a shock patient? Well, a shock patient without perfusion, diffusion doesn't work, therefore CO2 builds up, therefore I become hypercapnic, and I've got a high level of CO2 in the blood. Does the brain like that? No. No. They almost appear. And Jonah, that gets back to your altered mental status. The brain's not in a homeostatic bathed environment, is it? Is the stimulus to breathe been nudged with high CO2 levels? Yes. So what will be one of the first things to show up in shock? Careful, you're not wrong. You're not wrong. The body starts compensating, and I'm going to make a whole board over here probably of compensation mechanisms to shock. But I'll get an increase in respiratory rate, but it may still be within. That's why I hate the numbers, guys. It may have went from 12 to 16. It may have went only up 4 per minute, but it's still within what? That normal range we describe. His respiratory rate went from 12 to 16. Now that could be pathological. Logically, because of some pathophysiology. But it's what? It's normal. His breathing rate's normal. No, it's not. No, it's not, because he slammed his Buick into a bridge. And when you got there, he was breathing 12. In the ambulance at 16. At the ER, it's 18. Those are subtle changes, and if you're not aware of them. But why does the body do it? That's the bigger. That's the take-home message. Why is the body bringing up the respiratory rate? To try to get it back to normal, try to get that CO2 out, right? Why do we have CO2 building so quickly? Well, there's regions of the body that are perfusing poorly, therefore diffusion is poor, therefore I'm not in aerobic metabolism. Those tissues are in anaerobic metabolism. They're still alive, they're still working, but they are working very inefficiently, and they are producing a whole lot of bad. Those of you driving cars, if your air cleaner gets clogged up, like you never change it after 5 years, 10 years, you won't pass an emissions test if you had your car checked. You wouldn't like it anyway, because you're getting really poor mileage. You see a lot of black soot coming out of your tailpipe. The engine's not running cleanly because it can't get the oxygen. And so you produce a whole lot of nasties. Same way in your body. If your cells aren't running cleanly, they produce a whole lot of nasty. That's called anaerobic metabolism. And so we get excess CO2 levels. And so the body tries to get rid of that CO2 level, tries to compensate for that CO2 level by turning up the respiratory rate. This is a very early indicator, but there's one going on even before that. So the CO2, Gus, mixes with the what, Gus?
The water.
To produce what, Gus? Bicarbonate. H2CO3 from your chemistry class. Am I right on that? H2CO3. That H2CO3 is transported in the blood, and it gets back to the alveoli, and at that level this disassociates back into water and CO2. Do you guys remember me last week talking about some method that I had, or you have in an ambulance, to see how much CO2 is coming out of the body? Remember I said we put a device and it measures at the end of their expiration how much CO2 there is? And we said that's accurate as long as the lungs are getting perfused. Remember we had to have a VQ match? Remember that VQ statement. We had to have a VQ match. So as long as those lungs are getting perfused, we can get that CO2 out. As you treat shock, as you look at shock, as shock progresses, will you see changes in that CO2 level in that expired air? Yes, you will. It's one way of saying, am I doing a good job or not? Questions so far? No? It's a lot, isn't it? It's a lot. I feel bad. I really do feel bad because you just kind of sign up and you start. And I can't build a biology and an anatomy and a physiology and a chemistry and a physics background for you. K through 12 was supposed to do that. Supposed. So I kind of feel bad, but in another way I don't, because I know you're going to get it. So keep chugging, okay? Keep chugging. Remember, we talked about grip strength. You got to put the work in. This is just not going to appear. If it did, everybody'd be doing it.
Could you, in simplest terms, explain?
Mm-hmm.
Can't use the blood pressure, can't use that. So how, in simplest terms, how would you determine somebody's in shock?
Okay. Okay.
Injury.
We're going to get there, and if I don't do it when we get there, bring that question back up, please. Yeah. But I think you're on track. We're just going to look at it and go, they should be in shock.
All right, cool. That's the
I have said this to people before, and they're like, no way, you can't do this until you see your patient. Sometimes just a dispatch call, I already go, they're in shock. Helicopter fell out of the sky. They're in shock. I don't know what stage or how far, but they're in shock, right? Motorcycle accident on Highway 75, CPR in progress. They're in shock. They're in shock. Let me tell you a story, Jonah, since you brought this up, because you have an absolute a question that does not need to be. Your question is not deserving of an answer at this moment, but it's deserving of a concept, if you can follow me here. In other words, I'm about to show you why this applies, why your question applies, why everything this morning applies. You have talked quite a bit so far about sepsis, and I know why, because you see it so often in the ER. Sepsis, we're going to talk about it here in a little bit again, but sepsis is you got an infection in your blood. Your blood is supposed to be sterile. It should not have bacteria or viruses or fungi growing in it, okay? Blood is sterile. When blood is invaded by a pathogen, what is a pathogen? Some substance that causes pathos or disease. When your blood is invaded by a virus, a bacteria, or a fungi, you have an infection in your blood. Well, what that really does to the blood and the vasculature, the vessels, is it causes them to dilate. It causes them to open up. It's a form of shock we call distributive shock. In our Fick principle analogy, it's messing up the railroad tracks. The railroad tracks are not engaged anymore, and they've got holes in it. And at the capillary level, when I drew that on the board the other day, that fluid starts leaking out of the capillaries more than it should. So I haven't lost blood, okay? I haven't lost blood, but my container has opened up so much, I have relatively lost blood. You with me on that? We call that, it has a name, fluid container mismatch. Let's just say I've got and this is a guess, I can't measure it. Let's just say I have 7 liters of blood in my body. And I am normotensive. I am normoperfused. It means every cell in my body is getting perfusion. If I have 7 liters of blood in my body, that tells me my container holds 7 liters of blood. If I have too good a weekend and I drink too much and I get dehydrated because I'm using Coors Light instead of water while mowing the lawn, my blood volume goes down. Let's just say it went down to 6. It's pretty significant, but let's say I lost a liter. Sweat, dehydration, urination. You with me? But my container does what? It shrinks down to 6 too in order to do what? Keep all the cells perfused. You with me? If I drink too much water or I get an IV and they put too much fluid in my system, my vasculature will open up to accommodate for the extra fluid. In other words, it keeps it matched. In sepsis, the container opens up, but the fluid is now a deficit. Maybe I have a 9-liter container with 6 liters of fluid. I'm not perfusing all cells at that moment. That's septic shock, guys, okay? A fluid container mismatch due to a pathogen. And because people are so sick anymore, you're seeing a lot more of it in the ER. So let me paint this picture. This is a true story. The names of the guilty have been changed. And I will not tell you which service it came from. But it was about, 6 or 7 years ago now. So forgotten to a lot of people except for this patient, I bet. So this 50-something-year-old man, otherwise healthy, nausea, vomiting, diarrhea for 3 days. With me? That's a miserable 3 days, right? Throwing up, diarrhea, nauseous, 3 days. Then the 3rd day, he calls 911 and says, I just can't take this anymore. I'm too weak to drive myself to the hospital. Come get me. So an ambulance arrives on scene with a paramedic. The paramedic goes to the patient's side, grabs his pulse, his radial pulse, and it is fast, like fast. It's tachycardic fast. It's up there in the 140s, 150s range, okay? We actually have a page in the protocol book, if you will, for treating cardiac-induced tachycardia, or SVT. You don't know what that is yet, but you will later. It's just a cardiac-induced tachycardia. And we have drugs for that will slow your heart down and bring it back down into a more normal range. Because remember, I told you that once the heart rate gets so fast, that equation fails. Remember me talking about that? It reached a limit. So this guy also has low blood pressure. They take his blood pressure and it's 80/40. Okay. That looks shocky, doesn't it? And the paramedic makes the decision, this shock is caused because the heart rate is so fast. So if I get the heart rate down, maybe the blood pressure will come up. It's contradictory to the equation, but you just told me you understand that once it gets so fast, the equation fails. So let's bring it back down so the equation holds true again. So we have a drug that we can give you through the IV, and it will stop your heart. It will literally stop your heart for about 4 or 5 seconds, and then it'll restart, and you hope it restarts running at a normal speed. You can repeat that drug 2, possibly 3 times, especially if you call the doctor. Adenosine. It's a drug that it's a chemical that's already in your body now. As a matter of fact, when you drink caffeine, you're trying to knock adenosine off. So that's a different story, but it'll be cool later. So they give him the adenosine, they give him the drug. His heart stops. When it comes back, it's back in the 150, 160 range. They repeat the drug. It stops, comes back, 150, 160 range. He calls the doc, gets permission For a really high dose of it, it stops, comes back in 150, 160 range. Still on phone with the doc. And he says, I think I need to cardio. And that means they're going to apply the pads to the chest and they're going to charge the electricity, and it's going to pop him. It's going to send an electrical current through his chest. It's going to hurt. But that's our next line of treatment, to kick that heart in the butt and say, slow down. It's kind of ironic. Sometimes we kick it in the butt to speed up. But in this case, we're making it slow down. If I'm trying to kick it in the butt to wake up, I give him 200 joules, which is enough power to light up two 100-watt light bulbs for 1 second. But in the case they're using, they start with 50 joules. It'll light up a 50-watt bulb for 1 second. It's still going to hurt. So they hit him with electricity. Heart stops, comes back 150, 160 range. The protocol reads, if ineffective, increase dose to 100. Try again. Bam! Hit him again. If ineffective, increase dose to a max dose of 200. So at this time, he's back on phone with doc and going, hey, med control doc, I've hit this guy twice. I'm at the 200 level now. Any further orders? You can hit him 3 more times at 200, but get him to the ER. By the time they arrive at the ER, your ER, by the way, they have hit this guy 5 times with electricity and 3 rounds of drugs, and his heart always comes back to 150, 160.
Just stop for a minute.
Okay? He gets to the ER. They repeat their assessment on him, and all of a sudden, they start fluids, antibiotics, and adrenaline, a form of adrenaline to shrink his container. This guy's septic. You were on the wrong protocol, dude. You failed your assessment. You failed to recognize what type of shock this guy was in. You were thinking he was in cardiogenic shock when he was really in septic shock because you failed to do a good assessment. You failed to repeat the assessment when what you thought would have worked didn't work. Hey, maybe we're doing something wrong here. You think this ain't working.
What did you fail in that assessment? What part?
He failed the history, the 3 days nausea, vomiting, diarrhea, which has probably caused him to lose fluids. He failed to recognize the guy had a fever, which is an automatic indicator you're fighting an infection. He failed to recognize that this drug that he gave was ineffective. I did not get the desired outcome from the drug I gave. Why not? Bad drug, wrong circumstance. But he escalated it up to med control and got orders to do even more. Totally off track. Totally wrong. How many times was his heart stopped? Lost count after 8. You know what I mean? Every time they gave a drug, it stopped the heart, and every time they shocked him. So a bunch. He still lived. Despite the best efforts to kill the man, he still lived. He still lived because he was resilient. He was 53 years old, otherwise healthy. Now, if he had been some old man, they'd been doing CPR at the ER and they'd have never known why. Oh, he died of cardiac arrest. Poor old guy. No, you killed him. You killed him, but nobody would ever found it. Matter of fact, this patient goes up to the ICU, gets discharged 4 days later after mega rounds of antibiotics and getting himself straightened back up. And the story ends, as far as I know. From here out, I'm making up the rest of the story. This is just what I'm thinking. See if it makes sense to you. See if this would be a good ending to this story, if we have to confabulate some ending. So this guy's 53 years old. He's getting through he got discharged from the hospital. He's on the road to recovery. his buddies invite him to go deer hunting in November, and we're going to go up to the deer woods and hunt. You deserve it, man. Come on, let's go. You're better now. Let's all get back together and go hunting. Okay, sure. Goes to the deer woods. He's sitting around a campfire at night, talking like guys will talk. And he says, hey, how long were you in the hospital? He's telling his story, right? And he looks over at his buddies and goes, let me just tell you something, guys. I don't know what I had. They never really knew what infection I had. But you don't want to catch it. Because if you catch it, they got to shock you like 5 times. They stop your heart with this medicine. The guy never knew he was being mistreated. So what's he left to believe? That what else could he believe? So let's review. If some lawyer or somebody like me called bull it on that and said, you need to go get your medical records from that ambulance call, because if you went in for sepsis, there was no indication to shock you. Huh? There was no indication to shock you. That paramedic did wrong. You might look into that. Well, I will. Yeah, because they could have killed me. Yeah, I'm going to look into that. I might get some money out of that. So he goes and calls him a lawyer up, and the lawyer says, well, let me look into this. The lawyer calls him back and says, I'm not taking the case. You waste your money. Why would the lawyer tell him he's wasting his money? So we're going to bring a tort claim. The lawyer's asked to bring a tort claim against said paramedic. But the lawyer says, I don't recommend you try this because it probably won't hold up. Why wouldn't it hold up? How come you couldn't prove negligence? Was he negligent? Did he have a duty to act? Yeah. Did he breach that duty to act? No. Did he perform an act of omission or commission?
No, he asked permission before he went in.
Oh, I'll get the doctor too then. Did the doctor perform an act of omission and commission? The doctor's going to get an easy out. I only responded to what you told me. If what you told me was true, then that was going to be appropriate treatment. And I'm like, yeah. But he didn't tell you everything. He performed things that didn't need to be performed, and he omitted to do things that did need to be performed. Okay, so yeah, dude, that was wrong. It all looks good, but we don't have that fourth component of negligence. What's missing from that?
You got harmed.
Yeah, you're alive, aren't you? So you can't prove to me that what we did to you caused you any effect. Are you not better now than you were before I got there? Yeah? No proximate cause. So who's it up to correct this paramedic then? If the courts aren't going to do it, the system, right? Your own internal system of quality control. Do you feel like that paramedic needs to be re-educated? Do you think he needs to be put under some form of supervision until he can prove that he can clinically make good decisions? Do you think he was? No. And here's some truth. The medical director vouched for him and said, you know, it's really difficult to work out there. It's real easy to make mistakes. The medical director took up for him. Instead of calling that guy in and saying, you're going to stand down and go under supervision before you actually kill somebody, the medical director took up for him. Remember the very first day of this class I talked about profession? And my plane, the Captain Sully thing, my plane. Does that guy have that? Does the guy that I just mentioned, the paramedic that I just mentioned who performed that, is that the guy you want to take control of the plane? No. Jonah, all this goes back to your statement. What caught him? What messed him up? What set him on path to this failure? Looking at numbers, and numbers only. So that's why I got animated when you said something about, you know, the blood pressure and stuff. It's like, no, we have to play house. And by playing house, I don't mean a bunch of kids. I'm the mom, I'm the dad playing house. I'm talking about house, the TV drama, medical drama house. Now, it's not on air anymore, but it was good in the aspect of, let's look at everything, let's knock out things that it can't be. And that's where that paramedic failed. He didn't form a list of what it could be and narrow it down. He just went immediately to, this is what it is, and let me give you everything it is to fix that. Despite the best efforts to kill him, the man still lived. And then the funny is, I'm guarantee you the guy's like, man, you just don't want to be shocked because that shit hurts. See how you can get messed up in this? Now the EMT doesn't have that bag of tricks, that toolbox. The EMT doesn't have the toolbox that the paramedic has. And the tools in the toolbox of the paramedic are tools when used inappropriately can be deadly. And we kind of limit the EMT because you just don't have the time to go into deep pathophysiology of everything that can go wrong. So we talked about the buildup of CO2, we talked about the buildup of acids and waste. Basically, in the Oklahoma way of saying this, they're starving you, they're suffocating you, and you're having to swim in your own poop. That's what the cells are going through. They're starving, they are suffocating, and they're bathed in their own poop. Are you going to be happy? Is that cell going to be happy? Will it start to become ischemic? Will it start to die? The answer is yes, yes, and yes. Oh, here's a good board. There's nothing on it yet. Those of you who had high school chemistry know that the abbreviation for potassium, or the chemical symbol for potassium, is K, right? K for potassium. And you know that the chemical symbol for sodium is Na, right? Salt, sodium, Na. So every cell in your body has a sodium-potassium pump. There is actually a pump in your cells. Every cell has this, that is constantly kicking sodium out of the cell. That pump is kind of like the drainage pumps in New Orleans. They're always running to pump water out of the city because it's below sea level. Water's always coming in, so we always run the pumps to get it out. What happens if you shut the pumps off in New Orleans? The city floods, right? When the sodium-potassium pump fails inside the cell, because the slide behind me says something about cell damage, doesn't it? Comma, may lead to cell damage. Well, the cell damage is the sodium-potassium pump fails. Do you think the pumps in New Orleans require electricity to run? Can I have ATP without oxygen? Not very much. Do you think the sodium-potassium pump inside the cell requires ATP to run? Yes. And so if I run out of energy, what happens to this pump? It goes offline. And Gus says that diffusion is the process of moving a substance from an area of high concentration to an area of low concentration. So because the pump failed, this cell all of a sudden fills up with sodium. And what follows salt? Water. So water is going to rush into the cell too. From where? Remember that term from last week, interstitial space? The cells set and are bathed with interstitial fluid, right? And now all this sodium's inside the cell, so we're going to pull water from the interstitial space into the cell because water follows salt. At some point, this cell membrane will rupture, blow open. It will lyse. It will blow open. It will spill all of its contents out into the interstitial space now. And now all of that junk, because it's not a cell anymore, it's just junk, it's just ingredients. It's like the scrapyard of your cars. When all the cars are nice and neat and running efficiently, they look pretty good and they all function. But when they're scrapped and they go to the salvage yard, they're just shredded. It's just like, they're just junk here. It's a junkyard. So around this area is a junkyard. Necrosis. It is now dead. It is now dead. So now we've got regions of the body that were inadequately perfused that might have died, and now we've got this junk setting out there. Putrefying, rotting. Man, things just went from bad to worse, didn't they? And the wonderful trauma surgeon at the hospital takes you into the OR and sews you, puts your blood type back in you from a donor. You have reestablished perfusion. You have reversed shock. But now all this new blood and perfusion goes down and runs into the junkyard and says, I need to clean this up. And grabs that stuff and pulls it back and says, that's a lot of nasty. Let's go get rid of this. And so it takes it over to the kidneys, because the kidneys are super good about cleaning up blood, aren't they? I mean, that's what they do. Now you're going to clog them up. Now you're going to clog the filter with old gunk, old fibers. It's kind of like first got married, built a new house. Always wanted a garbage disposal because I never had one as a kid, and I thought that'd be cool to have a garbage disposal in the kitchen sink. My wife peels potatoes and shoves them all down in the garbage disposal. Did that work? They disappeared from the sink, but where were they? Well, let's take the new plumbing apart, Brandon, and take our little thing in there and dig out potato peels because they clogged the drain. If I've got cells in my body that have died and now it's been picked back up in circulation and moved over to the kidneys, now I have kidney failure because the filters got clogged. Boy, everything looked good up until that moment, right? Now the patient's on dialysis. Can those broken down fibers of muscle and cells and stuff clog up in the lungs? Can they clog up in the brain? Can they clog up in the heart? Sure, capillaries get real small, don't they? So sometimes reestablishing this stuff looks good, but we just don't know how much necrotic tissue there is, how much can the kidneys handle, right? Shock's ugly, guys. And I think Lord Kelvin said it best. Rude unhinging of life. And you don't know if it's today, tomorrow, or next week. Questions so far? We've covered a lot.
So what exactly is necrosis?
Just dead tissue.
Okay.
Dead tissue. But Gus, the problem here is you don't cut it off and throw it in the trash can.
Mm-hmm.
It's inside you. And so now you've got a busted open. Do what? Kidney transplant or dialysis? Possibly. Yes.
Can psychological trauma cause shock?
There is a form of shock caused by a sudden exposure to a traumatic psychological, I can't handle that. And we have a name for that, Jordan. Here's the difference, though, Huckabee. What I'm describing here and what you're talking about is all true, but it's reversible. The word is syncope. You were so stunned. That's called a psychogenic shock. You were so stunned that you passed out. You ever heard this before? And this is what you hear from lay people. When he got out of the car wreck, I think he was in shock. He just looked like, and then he passed out. And you look at the car wreck and go, there's a fender bender in the Walmart parking lot. But it freaked them out so bad because they knew that, Daddy was going to get on to him for wrecking the vet. He was so scared. Or maybe he was drinking, or you know what I mean? Just something about the event just freaked him out, and he passed out. And the bystander said, I think he was in shock. Not this kind of shock, that kind of shock, syncopal. And what syncope is there's just a temporary interruption to blood flow to the brain. If it was prolonged, then it would be some form of shock. But it was temporary. And it's just because, remember that adrenaline rush you got? We talked about that last week. That dump of adrenaline, that alpha 1, alpha 2 thing, it's so quick and so sudden that it just got out of whack. The body couldn't compensate, and it just went, you're going to have to reset. You need to get down and reset and come back to me in a better way. So that's called a syncopal episode. Syncope. It is a form of shock, but it's temporary. Just a little bit, and then we'll get our break knocked out for the morning. We've already talked about this. Got to recognize it. You got to treat it early. You can't wait till numbers tell you. You can't wait till the numbers show up. We've talked about this. This is the Fick principle. What do you got to have to maintain perfusion? You got to have a heart. You got to have an intact vascular system. And you got to have the blood. Not only that, and they should add this to the slides here, what would bullet point number 4 be?
Volume. Red blood cells. Oh, red blood cells.
So I'm going to assume blood's got red blood cells in it.
Oxygen.
You're there. Come on.
White blood cells?
No.
Dioxide.
Oh, you're there. You got to have a pump. You got to have the pipes. You got to have the blood. And what's the 4th one? What would be right here if this was a better slide? Respiration. Onloading, offloading. Right? Let's back up one more layer, Gus. In order to have respiration, I must have ventilation. Excellent. And in order to have respiration and ventilation and everything functioning, somewhere over here I must throw the ingredient called energy into the system, right? I got to have a digestive system. I got to get the sugars in. I got to get the proteins in. You see how it all kind of works? See how it all kind of works? You know this one. If I was to blot this out, every one of you could fill in the blanks, because I know you're that good. But this is a great slide to show you that this needs to be a closed loop system, doesn't it? You can't open this loop up and not have shock. It needs to be a closed loop system. I wouldn't use perfusion triangle. I would teach Fick principle there. Same thing. Same thing. I think Fick principle takes into that respiration, and we just really can't put that up here. Can anybody find in their example respiration? And I think it's critical to have that, don't you? You want me to prove it? Do you want me to prove how critical it is to have respiration in this? Gus, you want me to prove it?
Sure.
Series of questions. You can call for help if you need to.
Okay.
Does a dead man have a heart?
Yes.
Can I pump on that heart?
Yes.
In other words, can I do chest compressions to start the blood moving like the heart would? Okay, so dead man, got a heart. Does he have blood vessels?
Yes.
Does he have blood?
Yes.
So you're telling me I can pump on his chest, I can push the blood through the vessels. Is he alive?
No.
Why not?
Because he doesn't have the oxygen and respiration to.
So let's say I take my fancy back valve mask and I hook it to oxygen and I bring his pulse ox up to 94 or better. Then all of a sudden I have established alveolar respiration. Does that mean he's alive? Not necessarily, does it? Because he's still missing some form of the respiratory pattern. What is that? Huh?
Respiration.
I'm ventilating him. I'm compressing him. I'm getting O2 onto the cells or red blood cells because my pulse ox is going up. I'm moving it around the body.
Automaticity, where it's doing it by itself, or it being automatic.
How do I know if he's dead or alive?
Did you stop doing what you're doing or continue?
Right now, I'm performing life support. Basic life support, also known as CPR. But how do I know if he is alive or not? What has to be there? I've got alveolar respiration, but do I have cellular respiration? That's the question, isn't it? Keep thinking. How can I prove that the cells are functioning?
Skin tone check?
Pulse.
Capnography. Because if he's blowing out CO2, if CO2 is coming out of his exhaled gases, then something must be making the CO2, right? That doesn't mean his heart's restarted. That doesn't mean his brain's woken up. But it does mean that some cells somewhere in his body are producing CO2. Now, if he's 12 hours post-mortem in the morgue, non-embalmed, and I'm doing this, I'm not going to get any CO2 out, even though I make all the other things work. You have to have cellular respiration. You have to have all of it. And we have really cool tools to see if we can do that. Case study, and then if you give me a good answer, you earn a break. You ready, Aiden? So we find a man in cardiac arrest. Bystanders start CPR. 911 summoned, 911 paramedics, EMTs are on scene. They start CPR. They put him on a device that does chest compressions for them. They start IVs, they look at the heart monitor. He's in VFib, we'll talk more about that later. They shock him a few times. His O2 levels are rising, they're good. He's still in VFib, in other words, he's not a flat line. And his capnography reading is 38. What's the normal range for capnography reading? Anybody tell me from the last week? 35 to 45 is the normal range. He's at what? 38? That's good. That tells me what now, Aiden? If I've got CO2 coming out of his body, what does that tell us?
Cellular respiration.
Cellular respiration is occurring somewhere. Not only am I doing basic life support, I'm also doing advanced life support because I'm adding those other things to it. Transport this gentleman to the emergency room, and the doctor in the emergency room says, how long has he been down? Meaning, how long has he been in this state? And you go, well, from bystander, from time of call, I'm going to say he's been down 40 minutes. And the doctor says, stop it. Call it off. What's your thought about that, Aiden?
He's dead, but he still has CO2 coming out.
So he's not dead.
Right, but the doctor said to quit it after 40 minutes.
But he's not dead. He has a salvageable heart rhythm. It's not asystole. There is still electrical activity in his heart. It's just not organized. He's got good perfusion. He's got good numbers. He's metabolizing because he's blowing out CO2. All of his numbers appear homeostatic. The only problem is that heart rhythm he's in will not generate a pulse. It's chaotic. It's fibrillating.
It's almost like this
He's what now?
I can't even say the word rhythm.
He has an arrhythmia. Yes, he does. That's why he doesn't have a pulse. But the doctor says stop it because he's been in this state for 40 minutes. I look at this as, damn, he's pretty resilient. He's pretty resilient. He's still wanting to live, and the advanced and the basic life support has put him in a homeostatic state. Why don't we figure out why his heart is resistant to being normal? He's in persistent VFib. Doctor says call it. He's been down too long. What?
Irreversible shocks.
Here's where you're messing up, guys, and I hate to be this way. We may have to edit this. You're putting too much damn faith in the doctor. I'm going to owe this man an apology by the end of the day. But damn it. You need it.
So we tell the doctor no?
Can't tell a doctor no. What the hell's wrong with you? Are you prepared to tell the doctor no?
I mean, if it's a life or death situation, I'll tell
I
him.
might be prepared to tell him no, but are you prepared to tell him no?
Unless you're no doctor.
You're in a bad position. You're
Load him back in the ambulance, get him in the hospital.
you can't. You're in a bad position because of working in the ER, and it has instilled so much conditional bias in you that I'm gonna have to break it out of you.
Yeah,
You too.
yeah.
Please.
When we say 40 minutes downtime, we're thinking,
It's conditional bias, man. Your biases will bite you in the butt. And I'm going to have to break that. And if you go into paramedic school, they're going to have to break that out of you. You're drinking the Kool-Aid, dude. If you knew the ingredients of the Kool-Aid, you'd probably know something. Oh, you might... Do you know if you bring a cardiac arrest into the ER, in order for the insurance companies to pay for that event, it's got to go greater than 30 minutes. The attempt on that man or that person has to be greater than 30 minutes. You'll see a lot of ER docs calling it at 31 minutes. They'll say, what time will this guy get here? And what they're doing is they're adding 30 minutes to it plus one. Then they'll call it, so they'll get paid for it. If they don't think it's salvageable at all when you walk through the doors, they'll say, stop it right now, because I'm not wasting 30 minutes on this here. Who's in charge? No. Insurance company. I've had ER docs tell me that they need new tires on their Porsche. They're working more CPRs this week. This guy obviously has a lot to live for. He still has a salvageable heart rhythm. There are other things we can do. So instead of using one defibrillator, there is some cases to where if we double shock, use 2 defibrillators on the man, there's some cases where that worked. Are you saying he's brain dead because he's 40 minutes? I don't know. Let's say he's 40 years old. Should you do something for a 90-year-old you should do for a 40-year-old? You should. This guy is still in a salvageable heart rhythm. You just need to straighten it up. Are there people walking around with LVADs, left ventricular assist device? These are pumps that are put in the patient that they wear, and that's pumping their blood until they get a heart transplant. They don't have a pulse, by the way. You can't feel a thump, 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 because their pump's centrifugal, it's just spinning. If you feel anything, it's just a vibration. We call that a thrill. I don't know why they call it a thrill, but they call it a thrill. I guess it's a thrill if you got something. And you don't have a pump, but you got something substituting for the pump. Did all that make sense? Aiden, does that make sense?
Yes, sir.
Is the man dead? No. Is he brain dead? I don't know. Run the test. But I do know, because of the numbers, there are cells in his body, and enough of those cells that he is getting rid of CO2 at a homeostatic level. What if I added this to it? He has purposeful movement. What if he is reaching up trying to get that thing off of his chest? What if he's reaching up trying to pull the airway out of his mouth? Huh? At least the protective part of the brain is working, isn't it? This man had purposeful movement. When they would pause the Lucas, he'd go flaccid. The Lucas is the device that was pumping on his chest. This is a true story, by the way. I didn't make this up. I don't make up any of these stories. If I add an ending, I'll tell you. But the paramedics were like, "Doc, you sure you want to stop it? He's still in VFib. He has capnography. He's been down 40 minutes. Stop it. He's been down 40 minutes. Stop it." True story. Scary, isn't it?
So what you say, if it's 30 minutes or more, they get paid, or what?
Yeah, there is that too. I mean, I don't know that had any effect in here, but if you're going to get paid for a resuscitation attempt in the hospital, you got to work it. Be careful with quoting a number on that, because they will change the number on you. At the next revision of the Medicare, Medicaid policies, they'll change the numbers on you. Once you figure them out, they'll change it again. Here's an example. You're on scene of a critical patient from a car accident, a critical trauma patient, and you are in a very remote area with no strong hospitals nearby, so you need a helicopter to fly this person to Parkland or Plano or TMC. You with me? So the ground ambulance, who has been there for 30 minutes working on this, seeing this patient, waiting on a helicopter, cannot bill for transport unless they make one revolution of the tire. So if your ambulance is parked, you put the patient in the back of the ambulance and the helicopter lands right there on the highway, and you didn't move that ambulance, you can't bill for transport because you didn't go anywhere. Now, if you drove a half a mile down the street to get to the helicopter to unload, you can bill for transport. How far do you have to go in order for it to be considered transport? One revolution of the tire. So take a Take an 18-inch wheel and multiply it by 3.14, which is pi. That's how far you got to go. Right? And we work together on this. Like, if I put the landing zone a mile down the road, it's good for you. And sure, I'll take them because it's good for me. It's ugly. It's ugly. Modern medicine. Okay, it is 10:35. Come back in here. I'll give you 10 minutes. Come back here a quarter till, and then we will keep